Next, we're moving on to Borrelia burgdorferi, the agent of Lyme disease. This disease is named after Old Lyme, Connecticut, where it was first identified. It was first described back in 1975, so it is a relatively new disease. Ticks are the only competent vectors for Borrelia burgdorferi. And in North America, we see it associated with Ixodes scapularis and Ixodes pacificus. The ticks become infected by biting the primary reservoir host and then going on to bite another organism, another animal afterwards. It's really important to know that transmission is not instantaneous. It can take 24 hours for transmission to occur, so the prompt removal of ticks is a really important control strategy. In people, we see co-infections with Borrelia burgdorferi and other vector-borne agents, including Babesia and Anaplasma, and this is likely also common in animals as well. Here you can see the two vectors for Borrelia burgdorferi in North America, Ixodes pacificus in the western part of the continent, and Ixodes scapularis in the east and center. Interestingly, this broad theoretical range of Lyme disease doesn't really play out in what's seen clinically. We think that Ixodes pacificus really prefers to feed on lizards where Borrelia doesn't amplify as efficiently. And so the disease is more highly focused in the eastern part of the continent. This is some data from the US Centers for Disease Control. And on this map, you can see all of the cases of Lyme disease plotted. So this hotspot in Minnesota and Wisconsin, and then the Northeast corridor. In our companion animals, the most common sign of Lyme infection is nothing. It usually does not cause disease. Most commonly, they are subclinical. If they're affected, so in the rare case where we do see disease, the most common signs are intermittent recurrent lameness. Polyarthritis is the best documented syndrome. We can also see fever, anorexia, lymphadenopathy, and swollen joints. Rarely, fatal renal failure has also been reported, and this is thought to be due to immune complex deposition in the kidney, so a type 3 hypersensitivity reaction. But again, I just want to emphasize that in dogs, the most common clinical sign associated with Borrelia burgdorferi infection is nothing. It usually does not affect these animals. Similarly, we don't see disease manifesting in cats. Seroconversion has been reported, so there's serological evidence that cats are exposed, but they seem to be even more resistant. In experimentally infected animals, we see similar clinical signs in cats as we would in dogs. In cases where we do have clinical disease, early treatment is important, and drugs like doxycycline, amoxicillin, and azithromycin are recommended. Control is really about acaricides and removing ticks promptly. Remember, it takes 24 hours for the Borrelia organism to make its way from the tick into the animal it's biting, and so prompt removal can interrupt that transmission. We also have vaccines available. There's a variety of products from bacterians and recombinant proteins. Interestingly, these are really only available for dogs. In people, Lyme has kind of made its way into the public imagination, and there's conspiracy theories surrounding this organism, probably because it has somewhat non-specific signs or can have non-specific signs and can be difficult to diagnose. All of that is not to downplay the potential severity of infections. Symptoms typically occur 3 to 30 days post-infection, fever, chills, lymphadenopathy, swollen lymph nodes, and the characteristic erythema migrans or target-shaped rash, like you can see over here on this image on the right. Chronic signs occur days to months later and can include a wide variety of things, from a severe headache, arthritis, facial palsy, pain, heart palpitations, dizziness, inflammation of the brain, and nerve pain. So a wide variety of more chronic sequelae. These are some cartoons from the US Centers for Disease Control, and you can see again this classic erythema migrans rash, which does not occur in all people who are infected, facial palsy, and then swelling of the knee. In Canada, we do have Lyme disease as well, and it does seem to have an increasing incidence. This is some recent data from the Public Health Agency of Canada, so from 2023. And what you can see are the areas of the country where we have the highest frequency of Lyme diagnosis. So parts of British Columbia, Manitoba, Southern Ontario, and Quebec. and then the maritime provinces, particularly Nova Scotia. In Western Canada, Lyme has been identified in parts of Manitoba and British Columbia, although locally acquired disease has not been reported in Saskatchewan and Alberta. There were several cases in 2020, but these were all travel associated. If we break this data down a little bit more and look at it over time, here in this histogram on the left, you can see the number of cases of Lyme reported from 2010 through 2020. So there does appear to be an increase in the frequency of infection. And then in the histogram on the right, you can see the number of cases as well as the incidence of Lyme, so the rate per population. The important takeaway from this data is that we have the highest frequency of Lyme disease in Ontario, probably related to the large population of that province, but the highest incidence of disease in Nova Scotia. This is where we see the highest number of cases of infection per population. Other species of Borrelia are also potentially problematic. So Borrelia afzelii causes Lyme disease in Europe. This would be sort of Borrelia burgdorferi sensilato. Borrelia mayonii, which was identified in the United States back in 2016. Borrelia lone starii, which is vectored by Amblyomma americanum. This is associated with southern tick rash illness in people, as well as in birds and deer. And then Borrelia theileri, which is vectored by Rhipicephalus species and a cause of bovine borreliosis. Bartonella henselae is an organism that we really associate with cats, although clinical signs in cats are rare. It's been reported that 30 to 40% of healthy shelter cats are carriers, so it is very, very common. In experimentally infected animals, what we see is transient fever, papules or abscesses at the site of inoculation, lymphadenopathy, and myalgia. So at present, we don't know if cats who are treated for clinical disease go on to clear these infections with antimicrobials, and it's also not recommended to try and decolonize cats chemotherapeutically. There's a variety of Bartonella species which are theoretically implicated in disease in dogs. Bartonella vinsonii, subspecies Burkhoffii, is probably the best described, although there really isn't much data about it. Henselae, Clarigiae, Washoensis, and Quintana have also been reported. Endocarditis is seen with Vinsonii and others. We can see hepatitis in dogs associated with Henselae. And preventing these infections is really all about flea and tick prevention. If we have clinical signs, dogs need to be treated with long durations of antimicrobials, including enrofloxacin, doxycycline, amoxicillin, and rifampin. So a wide variety of treatment options are possible. I'd encourage you to take a look at a really good infectious disease reference like Green's Infectious Disease for more information on how to diagnose and then treat these infections. Cat scratch disease, caused by Bartonella henselae, is an important zoonosis in people. Symptoms develop 1 to 3 weeks post-exposure and can involve fever, a papule or pustule at the site of a scratch, like you can see here, and also enlarged and painful lymph nodes. You can also see bacillary angiomatosis, which is this vascular proliferation or angiogenesis at the site of infection. Bartonella quintana is a cause of trench fever. The name of this disease comes from what was seen in soldiers in trenches in World War I. So they would be bacteremic, have localized tissue infections, and potentially also endocarditis. Bartonella quintana seems to be reemerging in people who are affected by extreme poverty in developing countries and in homeless populations in developed countries. It's vectored by the human body louse, and humans are the only confirmed reservoir, although Bartonella quintana has also been reported in cats. If you want to read more about these important pathogens, I'd refer you to the US Centers for Disease Control, which has a great website with some sort of high-level overviews of these organisms. Bartonella bacilliformis is the cause of Carrion's disease. In people who have this infection, we see hemolytic anemia, localized tissue infection, and angiomatosis, so proliferation of vascular tissues. It's a biphasic infection. In the first phase, we see infection of erythrocytes, anemia, and transient immunosuppression. And then in the second phase, we get nodular dermal eruptions. So these vascular proliferations, this angiomatosis that can be seen on the surface of the body. Bartonella bacilliformis is transmitted by sandflies in the Andes Mountains, so in Western South America, and that's geographically where it's limited to at this time. For any of these infections, Coxiella, Borrelia, or Bartonella, our primary sample is really blood or serum. For Coxiella, we can also look at placental tissues in cases of abortion and milk to identify shedding. For Borrelia, if we happen to have cutaneous lesions, we can take biopsies to try and identify the organisms at the site of the lesion. And then for Bartonella, we can collect tissues on necropsy, such as vegetations in the case of endocarditis. Coxiella burnetii is primarily diagnosed using culture-independent methods. Remember, it's an obligate intracellular pathogen. It requires growth in cell culture or embryonated eggs, and so this is really only done in specialized laboratories. PCR can be used to detect the organism at early stages of illness. We can use immunohistochemistry at biopsy specimens, and then serology is probably the most important test which is done. This involves collecting an acute and convalescent serum and looking for that increase in titer, suggestive of a specific anamnestic response. It's important to know that cross-reactivity can happen with Bartonella henselae, Quintana, rickettsial species, Ehrlichia, Legionella, and Anaplasma phagocytophilum. Because in a diagnostic setting, we only detect Coxiella burnetii indirectly, its diagnosis can be challenging. I've put a link to an excellent video above where an infectious disease physician from the Mayo Clinic in the United States summarizes some of the commonly used diagnostic strategies. Bartonella species, on the other hand, can be cultured, so our more classical bacteriological methods can be used, although specialized techniques compared to growing an E. coli or staph are certainly required. We can detect signatures of Bartonella by PCR, and then serology is also the most common. Again, you need to be aware of cross-reactive antibodies, particularly with Coxiella and chlamydia species. For Borrelia, identification can be a real challenge. Serology is important, although interpretation is very difficult. Many seropositive animals are not clinically affected, and so what does that positive test really tell you? It may not correlate with the clinical status of the animal. Validation of serological methods is a little bit challenging because we oftentimes, or most frequently, lack a culture-positive gold standard in these cases. We can detect it by antigen capture ELISA. The organism can be seen in situ using fluorescent antibody. And of course, we have PCR-based methods as well. Zoonotic and interspecies transmission is really important for all of these organisms. Coxiella burnetii is capable of causing laboratory-acquired infections, and fatal infections have been reported. So if you suspect this organism, you must write that on your laboratory submission form. Make sure those lab workers can protect themselves. This is also a potential biological weapon. It's something which can be aerosolized and has the possibility of debilitating a large population. Borrelia burgdorferi is not directly acquired from infected animals, so it's all about vectors. And whether you want to consider this as zoonoses or not is maybe a little bit up for debate. It is, however, increasingly recognized. Perhaps the vectors are more common, and we're seeing changes to our climate that may impact arthropod biology and therefore the distribution and prevalence of pathogens like Borrelia burgdorferi. For Bartonella species, avoiding cat scratches and bites are key. So protective behaviors are very, very important. Flea and tick control is also important, although the role of these vectors in zoonotic transmission is ill-defined. And then just to reiterate, testing and decolonization therapy is not recommended for healthy cats. So we know many animals are at least exposed, and there isn't evidence to suggest that an intervention is required in the case that we know a cat has Bartonella. Susceptibility testing for all of these organisms is unfortunately impossible. For Coxiella burnetii, it's an obligate intracellular pathogen, so there is no Kirby-Bauer diffusion or broth microdilution testing. Treatment really relies on doxycycline. For Borrelia, doxycycline and the beta-lactams are frequently used. And for Bartonella, in animals, we would rely on drugs like enrofloxacin and doxycycline. In people, azithromycin, doxycycline, and the aminoglycosides are the treatments of choice. Have several new terms for today. and also questions for self-assessment.